me see. Okay, so this afternoon, this is a pre-form lecture, meaning that we talked a lot about basics today, but we made this pre-form design for users, new users, people that have some inexperience, and later this afternoon we're going to talk a little bit more intermediate advanced. So we're going to show you some things that we're doing, and if you're a new user or what we call a rookie in the United States, you'll start to see where in the direction that we're going with light forces. So light forces make a big difference. And I hope you all had a good morning. I hope you enjoyed your lunch. And I know you just had a big lunch, so we're going to try and wake you up. So we'll start with this. That's snow for you in Indonesia. So I hope you all had a good morning, not a bad morning. But that's indicative of making mistakes, isn't it? We all make mistakes, and the key is to learn from those mistakes, all right? And that's what we try, and that's how I try and teach. So it's very exciting for me to be here. I love Bangkok. I've been here, I think this is my 4th time to Bangkok, my 2nd Damon Asian Forum. All right, so thank you for the invitation to be here. Okay, so this is a decision that we all have to make, all right? Clinical judgment or science, because we have research from Dr. Hisham Badawi that tells us when we can engage a tooth or not, or bypass it. So every decision we make should be based on this. Should I fully engage that tooth? Is that the right thing to do in this case? All right? So look at the amount of arch wire bend here. I don't know if that's not coming up on my screen. Let me see if I go to the other screen here. Can you see my arrow? Yeah, there it is. All right, so look at the amount of arch wire. That's a lot of binding friction. For that wire to slide, we have to decide, is this a good idea or should we bypass? Okay? Should we attach the wire here and just tie it with a lig wire? Now, what option would you choose here in this case? Who can tell me what they would do? There better not be anybody in this audience that raises their hand, because you don't know what the face looks like. You don't know what the skeletal pattern looks like. You have no idea what the muscles look like. So how could you make that decision based on 2 pictures? And the answer is you can't, or you shouldn't be able to. All right? I can tell you what we did because this is what we did. And the reason I have 2 pictures is because I bonded the brackets. The staff looked at the chart, and we were supposed to put a 013 arch wire in there, and they engaged the teeth fully. But when I came over and sat down and checked the patient before they're leaving, I looked at this and I said, that's too much binding. I was worried about flaring the teeth. So this is what we did instead. We bypassed with a coil. That coil is only there to protect the cheek. That has nothing to do with the biomechanics. It's not active. It's just floating on the wire. But you see, this is a common thing that we do. We'll engage it. We put the ligature wire in the slot and close the door and just tie the wire to it. So we can now have the canine moving but with very minimal binding friction. Okay? So the decision is always based on what the case looks like. Okay, so when we treatment plan with binding friction, take a look at these two situations. All right, the first decision you have to make is what size arch wire should you put in? 012, 013, 014. So that's one decision. This is Dr. Badawi's research, which we didn't discuss today because it's again, there's just not enough time, right? But in his research, we know that when the teeth turned red, there was way too much binding friction, and that would cause side effects. Has anybody seen Dr. Badawi's research presentation? I'm sure a lot of people here have, right? This is the situation we would have here. There's very little binding, therefore the teeth would not turn red, and the wire should slide out the back. Here, there's a lot of binding. This wire almost goes up 90 degrees. And we know we can expect side effects on these teeth. Okay? So, should we engage or bypass this tooth? Because if we looked at his research, we would know these teeth are red. That we would have this situation, and you can see all the abnormal forces that you would have on those teeth. So you would have side effects. So the decision you have to make is, should we do that or should we not do that? Maybe we should put a coil on here and bypass that tooth. Okay. So what was the decision that I made? The decision was I did exactly the same thing that you see on the slides. I engaged both of those canines. Okay? Now, the question is, why did I engage this canine? Because that's a lot of binding friction. If you look at the incisors here, you see there's a little bit of overjet. Okay? A little bit of overjet. This patient is a little class 2. This patient is at the edges of their teeth. Class 3 tendency. So knowing I'm going to have side effects here, meaning that the teeth are going to come forward, is an advantage in that case because it's class 3. So I wanted that side effect. Now, how beautiful is that? When we have a system, when we have a force system that we can take advantage of friction when we need it and create a side effect that works for us, or we could take it off when it's a disadvantage. That's what we have with passive self-ligation. If you have a class 2 case that you're pulling a lot of elastics, and you know the incisors might flare a little bit, you already know that you should put low torque brackets on those teeth. But if you're in stainless steel wire, why can't you tie elastics over the bottom arch and create friction? Friction on, friction off. Wasn't that a Karate Kid movie? Friction on, friction off. Do you understand? So you can put friction on where it makes sense, where it is an advantage. But most times, friction is our enemy. Most times, we have to be careful where we use friction. I think the Karate Kid was wax on, wax off, right? Wax on. But we're going to talk Damon. Friction on, friction off. All right? And I'm not very good at karate. So, all right. So that's what we did. We engaged the teeth. The decision is based on the diagnosis, the face, muscles, and skeletal pattern. So if I know I have good muscles, and that case is class 3, and I want the incisors to move forward, but I don't want them to flare a lot, I can do that. And that was the decision in that case. So understand, it's just how do we use this new tool? It's using the tool to its best advantage. The biomechanics of the force system that you're using, it is very different than conventional mechanics. That's what we learned. We learned that over the years by making mistakes. unwanted forces can sometimes be wanted forces. Okay? So, early light elastics is a key factor. Let's look at early light elastics. I did a little short presentation on elastics for you. We're going to look at this and just look at some of the advantages that we can create by setting up our cases. Remember, Burstone talks about biomechanics. He is the guru of biomechanics. All right? He died a little over a year ago. All right? But his legend will live on forever. I learned so much about biomechanics from him. Now, biomechanics is know your force system, know what you have, and how to use it. And that's what's different about self-ligation. Now, Volha, she is a class 2 malocclusion, and she came to me with braces on. She had them on for 34 months. 34 months, and she came from New York City, and she's of Russian descent. And she went back to Russia to visit family and went to an orthodontist there because she was upset that she had braces on for almost 3 years. The orthodontist in Russia told her to find somebody doing Damon in the US. And she happened to be in New York City. She looked us up right across the river in Bayonne and came to my office. So this is what she looked like. Now, almost 3 years. Look at the molars here. So what did I do? I took her braces off because I knew that I was going nowhere in this case. All right, so she transferred. I didn't take them off. I sent her back to the orthodontist in New York to take the braces off. But look at the problems with the molars. I mean, I just can't imagine having braces on for 3 years and still have, there it is. Look at this. So we're going to talk about a couple things about how we set up a case, which is kind of unique, okay? She's got some root blunting on the teeth, so we're going to have to watch that. We're going to initial Ceph, right? She's class 2, and she doesn't have really good muscles. Why do I know that? Lower incisors are flared, aren't they? Upper incisors are flared. She's class 2. She's high angle. So she's a high angle with not so good muscles. Right? She needs veneers. All right? So we have an advantage that we don't have to make this case perfect. All right? We want to get these teeth in reasonable position for her to do veneers because she has tetracycline staining of all her enamel. Right? So this is post-debond. I mean, the case is a train wreck. In the United States, we call this train wreck. So I chose this to show you the advantage of late early elastics. How are we going to set this up? Okay. We know it's a high angle case, so that's difficult. We're going to use molar turbos to disarticulate this case because we got to control vertical, right? We're going to use Shorty 2 elastics. What do class 2 elastics do? They're going to extrude the molar, correct? So we must control vertical. We don't want to make the high angle worse. We're going to use a long coil, and I'm going to show you one of the tricks that we do. We're going to splint the lower right 4-3 occlusal and a coil from 6 to 3 to open up space for the 5. So you're going to visualize this in a minute. Okay. So there's our coil. All right. This is 10 weeks. Now watch what happens. This is the power of Shorty elastics. Now, this is bypass. This is a half a bracket on that bicuspid. All right. And we're going to wear the elastic to the molar. And look what happens. In one visit, 10 weeks, that molar is completely upright. And she had braces on for 34 months. God forbid 34 years. Okay. She could have been in 34 years if she didn't come to Bayonne. But, I mean, look how simple this mechanic system is. All right? And that visit, we debond this, we put a bracket on, and we get her rolling. We go to a full class 2. What does the shorty elastic do for us? It's helping that molar upright in one visit. That's not going to happen from just a wire. But we have a turbo on the second molar to control vertical. Same thing on the other side. Look at this molar. And look how fast, 10 weeks, we upright that. That's not just because of the wire. The shorty elastics help us do that. Occlusal shot. There's our molar turbos. All right. So, do you see this little splint? Let me go to this so we can get it on all the screens. You see where I bonded the canine and the first bicuspid? Why would I do that? To be efficient, where do I need space? I need it for the second bi, right? If I just put a coil on here, space would open here and here. But by splinting these two teeth together, the space can only open in the second bi region. And the coil pushes the canine forward, but it also takes the bicuspid with it. So all the space opens here where we need it. Does that make sense? This is 016 stainless steel wire put in a flame. Dead soft. Just put it on the teeth and bond it. So it's just dead soft wire, and I create a splint that allows the space to open only here. Okay? And that day, we can get the bracket on. So what's the observation in 10 weeks? With light force, this is what we did. Molar turbos allow intrusion on the 7s despite the shorty 2 elastics in a high angle case. What else happened? Molars upright in one visit because of the light force of the elastic and the night-tie wire. But key is the combination of both. That's what light elastics do for us. And shorty 2 elastics initiate class 2 correction to jumpstart our case. Simple mechanics set up by thinking about what the case needs. And that's how you should judge shorty elastics. Just look at your teeth, look at what you need to do, and that's where you put your elastics. There's no great science behind this. I needed to erupt a molar. I needed class 2 force. So we just stuck on a short class 2 elastic. And in 10 weeks, a lot of things that positive happened. So we're able to gain space. Now, remember, she's sitting here for 34 months. And that was not moving. That was her chief complaint when she came. My teeth aren't moving. So, generally there's two options. We either wear them from the 5 to the 3 or the 6 to the 4. All right? So those are, let me go back. You can take a picture of that. 5 to 3 or 6 to 4. And it can be on both sides or it can be on one side. Just look at what your case needs. So in this case, we did it on both sides, right? From 6 to 4 bilaterally, because we had problems with both molars. 4 months in, look at the canine moving into class 2. Remember what I told you about extraction cases? That sometimes we attach the elastic to the hook itself to pull it back into position. See, this is a class 2 end-on canine. I want it to be class 1. We think in class 1. So why not get that to class 1 so that we can apply our mechanics routinely? So I didn't wait to get a posted arch wire in there. I started the elastic to the canine at the second visit after we got the molar eruption. All right? And then we put a little tie back on. This is just a tie back to hold the space. Same thing on this side. Class 2 moves now from the 6 to the 3 to get the canine in class 1. All we're doing, and this is 2-ounce elastics. A quail for the shorty, a parrot when we stretch a longer distance. And the difference between those two elastics is 3/16 for a quail, 5/16 for a parrot. So when we're going to stretch it a longer distance, we use the bigger lumen on the elastic to keep our forces light. Now remember, I said I use mostly 2-ounce elastics today in my cases. That doesn't mean it's always 2 ounces of force, right? Because it depends on how far I stretch the elastic. If I go and stretch it into a class 2V over the canine and back down, I may have 2.5 ounces or 3 ounces of force. But the question is, I mean, what you don't want to do is be stretching a zebra that far or a moose, because then you're talking 4.5 to 6 ounces or 6.5 to 8 ounces of force. And I would tell you that that's not healthy for teeth. And you'll get a better response from light elastics. I will prove to that in the segment this afternoon. So we're going to talk a little bit more about advanced mechanics and show you what we're doing with 2-ounce elastics later this afternoon. So this is Moha. Her previous treatment was 32 months. I said 34. I stand corrected. I missed by 2. We treated her at 12.5 with Damon, knowing she was going to get veneers, right? The final ceph. Lower incisors a little bit flared. Is that a good compromise as opposed to extraction, upper bis? I think so. And guess what? It's now in the literature. You see who wrote this? Berta Melson. She's written a lot of anti-Damon articles. But now she's talking about it may be better. All right, let's read this. It suggested that proclination of the lower incisors results in gingival recession. Proclination is, however, a valuable alternative to extraction, especially when considering facial aesthetics in adult patients. I would rather flare lower incisors and permanently retain a patient than take out upper bis and collapse their lip forever. Okay? But I'm also going to show you what happens over time. An increase in overjet in adult patients has therefore traditionally been corrected by retraction of upper incisors, often in combination with upper premolar extraction. Unfortunately, correction of overjet by incisor retraction does not always lead to improvement or even maintenance of facial aesthetics, especially in adult patients. You can't get that from anybody more conservative than Berta Melson. All right? That's a total 360-degree change from some of the stuff she's written about passive self-ligation and active clip self-ligation. Okay. All right. Second article, written by the same pair. This is in the AJO. The first one was in the European Journal of Orthodontics. And look what this says. Gingival recession or mandibular incisors did not significantly increase during orthodontic treatment. After treatment, fewer than 10% of subjects had gingival recession greater than 2 millimeters, and a follow-up visit, 5% of existing gingival recession had improved. 5%. I will tell you that with passive self-ligation, that number is a lot greater than 5%. A lot greater. I see it in 90–95% of my cases. And you're going to see that later this afternoon. That's her final result, 12.5 months, and then she disappeared until she comes back. This is, look at this. Now, I'm not talking about the color of the veneers, but you know, when they go white, right? This is called chiclets, chiclet white. 7 years, 10 months later, look at this. She still looks great. Do you see any detrimental effect of the lower incisors being flared? Zero. She walked into my office. I hadn't seen her. She just disappeared because she was in New York City. She walked in because she wanted me to see her with her veneers on. She did a little facial cosmetics, too. But look at that. Now, again, I would have did a couple shades darker, but it is what it is, you know. I mean, that wasn't my choice. So she walks in all those years later, and here's the retention ceph. All right? Initial ceph, final ceph, retention ceph, 7 years, 10 months. Look what the muscles did to the lower incisors. Did those incisors upright here 8 years later? Did I do that? No. Even in a high angle case, remember that the next time you think about taking upper bicuspids out. Don't do it. I destroyed enough faces to know it's not a good thing. You know, you collapse lips, you take their lip away, and they look 20 years older. At 40, they look 60. At 50, they look, I want to say that because they start looking like me. But that's what happens over time. This is pre-treatment, post-treatment. Retention ceph, when we took her braces off, 7 years, 10 months later, look what muscles do. And she didn't have great muscles. Teeth move forever. Retention must be forever. And you can get positive or negative results in retention. Okay? But this is why I brought Boha. I mean, she just came out of nowhere. And that's amazing to me that that much incisor uprighting occurred in a high angle case. So think twice before you decide to extract teeth in a case like this. Think twice before you even take out a lower incisor, which is another thing that I did. Because now the literature is saying maybe it's not such a bad idea in these adults to get facial aesthetics. Yeah, I would have liked to see veneers that were somewhat a couple shades darker. You know that's New Hue 62, right? New Hue 62, because you see plenty of denture patients with that color, right? They all want white teeth that they never had, but that's okay. Started with that. And she looks great. She does. So I wanted to show you that. By the way, this is your marketing tip. When you take photos after treatment, we take 3 extra smile shots all the time. We have them tilt their head. Just do anything they want to do, right? Guess what pictures go up on Facebook? It's free advertising. 3 extra pictures. Take your straight-on smile shot, and then take, you know, have them do. My staff is good. They just say, tilt your head, laugh, and they take a picture. But look at that. I mean, she is so happy with the way she looks. I would take spray paint and do a little bit of darkening of the teeth, but understand that's what we get. Okay. So I want to show you that little segment because when she walked in, it was like uncanny that day. She just happened to walk in with her husband and her baby, and I just thought that was incredible. Right? So many times we get these patients back in retention for that reason. Understanding the biomechanics, the wire technology, and the biomechanics. So we know that we engage that canine, we get the big force drop-off right here. Right? This canine's way back. Look at the deflection of that wire. So the wire goes soft or martensitic to drop off, and then light continuous force through here. What about the other canine? Still a force drop-off, but not as much. So what do we expect? More force on this tooth, it should move faster. Less force on this tooth, which has to drag through all that bone. Isn't that a good thing? To have lighter force on that? So there it is. That's what Burstone is teaching us in his article. This tooth is moving slower, but it needs to move slower. It's got to go through all that bone. We don't want to hyalinize the ligament. We don't want to move teeth. We want to move teeth by frontal resorption, not undermining resorption, right? And here, this tooth, which didn't have a long way to go, moves right into place. So there's your wire right there in the clinic. There's your hysteresis right there. Just what Burstone was teaching us. That happens if the wire can go out the back. If it doesn't slide out the back, we can get into trouble, like in this case. All right? Good idea, right? Put loops on the canines, feed the wire through, very little friction on those, right? So that should work, correct? Except for what? What's tied down? The posterior teeth, right? Wire can't slide out the back. This is a great idea. But if the wire can't slide out the back, guess what happens? There's your spring. Okay? So the wire has to slide, not to have side effects. And there's a perfect example of what can happen when you have friction. Here's another case. Look at the lower incisors tied down, upper incisors indentation. What's happening in the lower? See, the teeth are expanding out, tipping. In the upper, all the crowding disappears and the teeth stay upright. What controls that? Muscles. This is what friction does to us. That's what muscles allow to happen. So friction and binding friction can create unwanted forces and undesirable side effects. How important is this research? Burstone told us. We want to minimize these undesirable side effects. Period. And that's what I think we can do. But no system's perfect, because we can mess up. No system's friction-free. There's always binding friction. Okay? Friction-free is when I showed you the rotated bicuspid. Just put a chain to it. There's zero friction. Understanding this is the key to using this technology efficiently. So, all these are side effects. And this is even side effects in passive silicate. Look at the bottom picture. Extraction case. You would think you could engage this. This tooth would move right down into the space. No. Too much binding friction. Therefore, we got side effects. So you can get side effects in passive self-ligation. My microphone? Okay, good. Sorry about that. I sometimes move too much. Okay. So, I showed you my penguin friends. And I showed you we get tripped up sometimes. Well, we also can get even because we learn from our mistakes. If we learn from our mistakes, we don't get tripped up, we get even. Okay. There's archwire charts. There's sequence charts you can get. They're in books. They're published. Ormco has them. But remember, it's not a cookbook. You must be an orthodontist. You must think about what you're doing. That's just a guide. I took you through the archwire sequence. But you got to change it. You got to use more round wires in crowded cases. You got to bypass teeth sometimes. You just judge that by the muscles. If you have good muscles, you don't have to worry about it. So it's just learning to use this system properly. That's why I'm here. Many of you have been doing this a long time, but you start making mistakes and you forget. You go back to some old things that you did when you were trained in school. Here, for people that are here doing it a long time, and I see a lot of you, I know a lot of you. I know you've heard me before. So I try and show you, let's get back to basics. You've always got to go back to basics. If you're a baseball player and all of a sudden you're missing the ball and you're striking out all the time, what do? They go in the batting cage and work on getting back to their swing. Right? It's always just practicing. It's analogous to using a hammer or a nail gun. If I give you a choice, right, about building a house, how many people would take a hammer versus a nail gun? Right? Certainly a nail gun is a lot easier to use than a hammer, right? But if I give you that nail gun, I give you the nail gun, and you walk up to, say you're going to build a dog house. We're going to make it easy on you. Small little house, right? So we take the nail gun, and we go up to it with the nail gun, put the board down, and we do this. Is it going to work? No. You're supposed to shoot the nail in. It's a nail gun. All right, so you got to use it the right way. If you don't use it the right way, you get in trouble. Just like these guys. I put this in to wake you up after lunch. And if anybody's ever heard me lecture, you know you've seen this video, but I don't care. It's still funny. You don't want these guys building your house. I've done this. Don't get distracted. In slow motion, it hurts more. Sometimes life hits you in the head with a brick. Don't lose faith. Does anybody know who said that? If Chris Chang was here, he would tell you. So who said it? Steve Jobs. Chris Chang will tell you, he knows everything about Steve Jobs. Okay, so it always comes down to this. Always comes down to the face. Face and skeletal pattern are first, then we look at the muscles. How do we tell muscles? We look at the malocclusion. We look at the dental volus. Advanced diagnosis and treatment planning. Okay. Muscles with PSL, we know it has an effect. This is our force system, PSL. Okay? That's our force system. But we have to set up a mechanics plan with that force system. We either engage all the teeth or bypass teeth. That's the mechanics plan. That's your secondary force system. You are responsible for the secondary force system that you set up. How you strap up that case, what teeth you bypass, what teeth you engage, you're creating the secondary force system with the PSL bracket. Okay? Then you have to decide the biomechanics. You make that decision, I should say, based on the biomechanics. And then you need to utilize or avoid side effects. Like I said, I showed you where sometimes side effects have an advantage in a case. So let's look at Jennifer. Now, this is a case I've showed many times, but for people that have not seen Jennifer before, we're going to go through it quickly. But I want you to see how you can set up a case to work the side effects for you. She's 27 and a half years old, all right? And she's got retroclined incisors. She's got a big collapse on this side, right? Let me go ahead and take your picture. And she's got, it looks like somebody punched her, right? Pushed her teeth in. And she's collapsed on one side. So what happened here? Maybe early loss of baby teeth, something, where teeth, fell out, teeth shifted forward. But regardless, all right, we've got very crowded malocclusion on that side. Okay, look at your ceph. What does that tell you about the muscles? Pretty strong, right? Incisors are very upright. You don't have to have numbers on it. Everybody can see that those incisors are pushed in and standing there upright over the bone. There are the numbers, 98 and 88. So very upright incisors. Look at her lips. Do you know they're strong muscles? Not by looking at them, but you know by looking at the ceph, by looking at her teeth, that those teeth are collapsed. She's got beautiful blue eyes, like my wife. Put a plug in for her. I love these blue eyes. They're just gorgeous. But anyway, what are we going to do with this? Totally blocked out canine. Blocked out canine on the bottom. And I just want you to pay attention. I'm going to show you just one thing right now. And I just want to keep this in mind because we're going to talk about that as we go into the case. I want you to look at this bone back here. Okay? That's modeling. Where is the canine? It's lingual. Did the cortical plate modify itself to fit that tooth? Do you see that with impacted canines on the palate? Big bumps? Is the cortical plate not modified? That's modeling. Modeling by Mother Nature to accommodate the position of the tooth. Why can't we reverse that? As we move the tooth gently in the direction it needs to go, will the bone not model on the lingual? When you pull impacted canines into the palate, from the palate, into the arch, do the bumps stay in the palate? Or do they remodel and reshape? So remember that when we look at this case. Low torque. We're going to talk more about this on Friday. Low torque on that lateral. If you have a high canine, the lateral is always back. Right? That canine is sitting on the root. Guaranteed. Okay. So what's the force system, the secondary force system? This is our case setup. Selective torques, fully engage or bypass teeth with coils, and the wire sequence. That's our secondary force system. We decide that. We also must disarticulate. And all the above is the decision of the doctor, isn't it? We set up the secondary force system. But you have to understand, PSL is the primary force system, and you can do things differently than you can than conventional mechanics. So, can binding friction help us in some cases? Unwanted forces we know have side effects. But can the side effects be sometimes wanted forces? The answer to that is yes. So that's why I did this. Take a look. Crazy, almost, right? Why would I do that? Now I know that the wire can't slide out this side. It's stuck, right? Because of all the binding friction. That wire going in and out of the brackets, those teeth are red on Dr. Badawi's research. But these teeth can't, that wire can't slide on that side. So that means I create a spring here, right, to push this way. Where's her midline off? So the spring that's pushing the other way is going to help fix the midline, right? This side, we start one shorty class 2. Why is that? Because I want to help this bicuspid lift without the side effect on the molar. One shorty class 2. Let's go back to this side. Where would you put an elastic here? No advantage. So why do it? All right, setting up the force system. Okay, one elastic. Okay, so if we know that this wire can't slide this way, it creates a spring, pushing the teeth this way. That's our midline. It's going to help us. So the side effects work here for us in this case. What about here? Binding friction. Is this tooth going to slingshot forward into position? No. If that was a steel wire, it would slingshot it. Then we would have a problem. But the fact that it's a super elastic wire, we have that nice gentle force on that tooth that's most out of position. So that canine should move with gentle force. Okay. 2.5 months or 10 weeks. We have a turbo on here. Look at this canine. See how nice and slow it's moving into position? Should that allow the bone to move with it? It did on the lingual. It modeled on the lingual. Why won't it model here? And the canine's working its way in and the midline's starting to shift. There's our turbo, unilateral. Second visit back, 4.5 months. I'm just going to let the slides show themselves. Here's the bite. Look at this bicuspid because of that elastic. Same thing we just showed you in Volha. Help the tooth up. Why not? How about that? In 9 months, what does the midline look like? Right on. What did I do? I leveled. I went through 3 round wires. A 1-3, a 1-4, a 1-6. 3 round wires. And I let the biomechanics do its thing because I understand the force system that I have, passive self-ligation, and I set up my secondary force system to work in my favor. So I don't have to overwork. Right? Nothing for anchorage. Didn't have to wear a headgear to disallize that side. It's all going to happen because we have a great force system that we're working with. Eleven and a half months, we're going to do a couple repos. I repoed 3 brackets in this case. We're going to talk about bonding next. I'm going to show you how I put brackets on. And for people that, I don't know how many people have ever seen my bonding presentation, but some people may have seen it when we did it. But I'm going to show you how we approach bonding, make it simple. Now, look at the progress up. Do you see a lot of flaring of those incisors? It can't flare. Why? Because we know we've got really good muscles you can push against. Can I prove it to you? Upper incisor was at 98. Where is it now? 97. Measurement error, right? So it's essentially stayed the same, 1 degree. Look at the lower incisor. Went from 88 to 89. How could that possibly happen? All that crowding and the teeth don't move forward. The reason it can happen is because this is happening. The transverse is happening. That's where the space comes from. When you look at a collapsed dentition, when you look at your models, look at your photos, it begs to be treated non-extraction with light force. The case is begging you to do it. Right? 3 teeth. There's 2 centrals for smile arc. I want you to just notice, and we're going to talk about this next. See the canine? Now, I had no idea at that point what I wanted to do. You know, I stuck the canine on the average position, you know, dead center, right? What I did in reposition is I moved it mesial. I moved it mesial into the rotation. We're going to talk about that when we talk about putting brackets on. Every bracket you put on a rotated tooth should be toward the rotation. So you pull the rotation out. So you offset your brackets. We'll talk about that next. And you don't have to put it back into perfect position when you've rotated the tooth. And the reason being is that you never fill up the slot. If we were putting in 22, 28 wires, you'd have to reposition it. But you're only going to 1925, and we have 12 degrees of play in 2 directions. So So you never have to reposition. You just get a hold on it. We'll talk more about that on Friday. Okay. See how far I put that? I took it from here and moved it mesial. And it's going to pull that rotation right out. Now, I would have done that here, but I just couldn't tell. You know, at that point, that two's so far out of position, so sometimes nobody's perfect. Can't get every bracket on perfect. Right? But once the teeth level out, then you can tell. So here it is. I set up dentalveolus muscles, and I set my biomechanics up for my mechanics plan to utilize the side effects. So I want to show you about canine expansion. See, canine expansion is definitely a source of relapse. There's no doubt in my mind that if we expand canines like this, we tip these canines out, that's going to collapse. But Melvin Moss said we could what? We could upright canines. Difference between expanding a canine, let me prove that to you. So I size corrected these two photos, and I drew a line on the tip of the canine to the tip of the canine. I'm going to copy and paste it and move it over here to prove to you that I don't expand canines. Oops. I did expand the canines, right? No. I uprighted the canine. Because if I draw a line here to the gingival margins and copy and paste that and put it back, all I did is model the bone to hold the tooth like it modeled here on the lingual. I uprighted it. And we can do that. And that is stable. Uprighting teeth over their apice is what Melvin Moss said we can do. Read it, 60s. Functional matrix hypothesis. Right? We can do that. And we can do it without the fear of relapse. But if you do this, that'll relapse. Okay? Can't tip teeth, but you can upright them. So, if it modeled here, it will model here as long as what? We don't slingshot it. We move it gently to let the bone go with it. Bone went with it here, bone will go with it here. So how do you tell? There should be recession. There's no recession. You'll see. Look at that. It remodeled. It modeled on the outside like it did on the inside. Now we're in 20-degree set wire to get more torque because she's under torqued still. You see what I mean? Look back here, and look how this bone is modeling back. All of a sudden, the cortical plate on the lingual is changing, right? Because it doesn't need to be out there to hold that tooth anymore. TMA to finish, because we're going to put a little bit of torque into the lateral. 18.5 months. And that's her final photo. Why did she look like that? The day she came in to get her braces off, we had a horrendous thunderstorm in Bayonne, like we had last night, about 10 o'clock, 11 o'clock. Was anybody hear that thunder and rain come down? She walked from the parking lot to the office and was drenched. Her clothes were soaking wet. Her hair was soaking wet. She was freezing. It was summertime. We had to put a blanket on her to take her braces off. Right? So she said, "You can't take my pictures. I look terrible." I said, "Listen, I promise you I'll retake them, but I'm going to China next week. I need to show your case." So she consented. We took the photos, right? And then we retook them. I promised her we'd retake them. So that's our real final records. 18.5 months. What did I do? How hard did I work? I leveled. That's it. Because I understood the biomechanics, I understood my force system, and I set up the secondary force system to work for me and her. So it makes my life easier, makes my staff's life easier, makes the patient's life easier. And I don't have to listen to my daughter complaining about wearing the pendulum appliance. All right? Okay? Understand, that's what this is about. It's making everybody's life easier and making everybody happy. Like I said, I don't have a single SARPI patient that was ever happy with me or loved me. Not one. They hate me. All right? 18 and a half months. Look at that arch form. Who determined that? Not me. It's crazy to think it's that easy. But it is, as long as you understand the tool you're working with. So I showed you my children, all treated with conventional mechanics. You can still be a good orthodontist with conventional mechanics or active clip, but it's so easy to do what we do and get beautiful results and not have to work so hard. Is there anything wrong with that? And still get paid? It's almost like this case, I felt like I was stealing money because it was so simple to treat that, right? I mean, 18 and a half months for adults. Remember what I told you? My adults were taking less time, and I couldn't figure it out. Well, she was the one where I went back and I kept looking and said, how is this happening in such a short period of time in an adult dentition? Made no sense. When I look back at the charts, I saw how many times we retied on these older adult cases. Bad Ceph, because she was tilted, but you can see the teeth are still not flared. And we worked to torque them even more forward to get her better lip posture. You see, look at her upper lip. Still a little bit flat. That's the best I could do. That smile is awesome. That'll make your day. Facebook. And for somebody who didn't want a picture taken because her hair was wet, my staff still got her to tilt her head and take a picture. That's how excited they are. They don't care about it. She forgot about her wet hair. You know, she just took the picture anyway, right? But she didn't put that on Facebook. This one went on Facebook. Okay. So time is it? 2 o'clock. We're breaking at 3, right? Okay. Let me just... 3:30? No, we're 3:30. We're going to 4 o'clock. 3:30 we're going to break? Okay. All right, good. So I have time. I can't find my mouse again. There it is. This phantom screen with Windows 10 drives me crazy. Okay, so let me just show, I know a lot of people are using this, but I'm going to show quick for people that have not used the bracket system or just beginning to use the bracket system. I'll show you a little bit about Damon Q, and then we'll move on. Okay, so the nice thing about this chamfered edge on the bracket is we can close the door easier. Just have to seat the wire in the base of the slot and then close the door. So it works a lot easier. This is an opening and closing plier. All right, this is how simple it is to open this bracket. Put it in that slot, all right, and you just twist it. All right, watch it. Here, in the slot, turn. I mean, there's no pressure on the teeth whatsoever. I love Q for that reason. We used to have the push button on the 3. You used to push it in, and you had to really push on the tooth, and the door would pop open. If it got calculus in it, that would be a problem. Right now, there's nothing. I don't care. You bury that tooth in calculus. You put that in there, you'll break the calculus. You know. So it's great. We use a fingertip to close it. We have a closing end plier, too, that you can seat the arch wire with. So you can push the arch wire into the bracket and then close it by squeezing this down. I don't think my staff ever uses that. We have it, but it's just so easy to close a bracket with your fingers. Put the finger on the wire, push it in, and close it with your thumb. So, you see this bracket ID? This is a great thing. You can always tell when a bracket comes off what bracket. That's the second quadrant, third tooth. I challenge you, the only time you're going to see this number inside that slot is right now. I can't see it with loops on and a magnifying glass. So I don't even know, it's got to be a patent issue why they have that number in there, but you can't see it. But it's there. All right. So what's that tell you? Quadrant 2, tooth number 3. All right, that's what that tells you. All right, but if you're young and have good eyes, maybe you can see that with loops, okay? But not me. I have great eyes. I had 20/20 vision when I had 20/10 vision as a kid. 20/10 is very good. It's 10 better than normal, right? And then as I got older, I went to 20/15. When I was a little kid, I could see the seams on a baseball when it was moving. That's how good my vision was. So it's heartbreaking to wear glasses today. Now I have very little, I use this for reading, and I have very little distance correction, but 3 years ago I had to get a little distance correction. That was depressing. I stayed in bed for a week. No, I'm only kidding. So, high-low and torque, it's green, red, and blue. All right, so your dots on the brackets indicate what torque you have, and that's going to be on the front of the door. And your jigs also indicate that. So your jigs are colored. All right. We have a horizontal slot and a vertical slot. Here's an example of how to use it. You can put a segmented wire up top. Here's a door that opened. We're going to pull that tooth back into position, then close the door. Here's another way of doing it. You got your spaces closed. Instead of putting chains on, you can put a little wire in here, segmented wire to hold your teeth closed. Friday, I'll prove to you that rotation problems are going to go away for you. Why don't you understand what's going on inside the bracket? All right. Always place the sectional wire. This is a tip. If you're going to use a sectional wire, put it in before you put your base wire in. Otherwise, you'll drive yourself crazy trying to get it in. You put the sectional wire in first, then you put your base wire in. It's very easy to do. If you put the base wire in, you try and get this wire in, you're going to spend like a half hour to do that. All right? The tips of the plier get in the way, it hits the wire, so don't even think about it. There's your jigs, and again, they are going to be green, blue, or red, depending on the torque. And Damon Clear, this is an awesome brace. It's the best I've ever seen, the clear brackets. It came with rotational problems, supposedly. But and they did a fix. So there's a newer version that less rotational problems. But I'll show you Friday how you'll never have rotational problems with clear again. Okay? Promise. Never again. You need the jigs to be able to see where you're putting the bracket. This bracket's so clear. Okay. Okay, so this is set wire. This is important. I want you to understand, this is the 20-degree wires. We put our brackets on. We're going to use our selective torques. But at any point in time, we can add 20 degrees of positive torque or 20 degrees of negative torque, like I showed you, okay, by just flipping the wire over. All right. This is not a non-extraction. It virtually eliminates the need for most auxiliary appliances. All right? So we don't use, that's the extraction case. Forget it. I showed you that already. Pre-torqued arch wires, this is what I wanted to get to. I don't know how that slide got mixed in there. Anterior 20 degrees set. Quick look at the advantages of the system for control with pre-torqued wires. This is where you get torque, when the wire's up on its edges. Okay? That's how you get torque. So, when are we going to use these set wires? Treatment planning issues. Positive and negative, like I said. We can use reverse curve wires with 20 degrees torque. That can only be positive. Do not ever flip over a reverse curve arch wire. I did that once, and teeth went all over the place. I mean, I was like, I scared myself. I brought the patient back in 1 week, and I looked at him and went, oh my God, what did I do? Yeah. It was scary looking. I took it out and just let the teeth settle for a week. Right? Don't ever reverse a reverse curve. Okay? Orthopedic setup. So again, facial issues. This is where we're going to use these set wires. So let's look at some clinical examples. Maximum anchorage. You can torque. If you use elastics with it, you can just take the root back. Let's look at this guy. Class 2 case, we put a Mara in. He didn't want to have braces on. He wanted to wear a minimum amount of braces. So I put the Mara in to correct the class 2, and I couldn't finish him. Right? Why couldn't I finish him? His incisors were upright to begin with, and what does a class 2 corrector do? It detorques him more. So I couldn't get the lower jaw far enough out to get a good facial result. So I had to go and put brackets on to torque him so I could get the jaw to come out further. Okay? So there it is. What did I have to do? I need torque. So we put the brackets on. And here we have minimal anchorage. We can just let the tooth flare if that's what we want. Or moderate anchorage, we can control a little bit of both. Okay? So you can do all those things depending on how you set it up. This is his finish. Look at his profile now. Look at the torque. It's so easy to torque teeth with super elastic wire. Light force, and I don't take off roots like I used to with Warren springs. That was my torquing apparatus. You know, everybody probably knows what Warren springs are. You put them on the rectangular wires, you have that spring pushing against the tooth. I got plenty of x-rays to show you how many roots I took off with those things. So that's the initial. Here's the stage 2. Here's the final. Torque control. You need this because we have play in the system. We don't ever fill up the slot. So you need to use your torque, pre-torque brackets. And I use a lot of auxiliary torque with the 20-degree wire, both positive and negative. Don't anybody tell you that the torque is in the base. Torque is on the edges right here of that wire. That's where you're getting torque. That's what we did to the incisor. And you look at the root. Still there. What did that allow us to do? That's where we couldn't torque them anymore. We couldn't advance the mandible anymore. Look at the change when we could have torqued those teeth and get the mandible to come out where it belonged. That's all it takes. Okay, we're going to talk a little bit about bracket position now. I want you to look at that central incisor. Is that going to work? Tooth is overlapped already. Where's my torque going to go? What's going to happen to that root? It's going to get worse, right? My son bonded it. My staff hit it with a curing light. I didn't have a second cup of coffee. I don't know. All I can tell you is I put that on and I put it on wrong, right? So what's going to happen? It's going to get worse. And that's exactly what happened. So are you going to wait till 1825 because that's what I told you to do, reposition brackets? No, you got to change that right away. You want to keep moving that root worse. The worst thing in the world is when the patient comes in and said, my front tooth that was crooked, it's more crooked, right? You look like a, yeah, well, so you fix it right away, all right? And the mother says the same thing, right? It's like another thing in Damon. You know, there's a lot of times where we put a, light wire. I'm talking management now, right? Put a round wire in there, especially when we had only one. It was 014. So we used to put the wire in, right? Check the patient in 8 weeks. Still wasn't ready to move to a 1625. So we would send the patient back for another 8 weeks. Patient walk out to the waiting room, and mom would say, "What? What did he do today?" "Nothing." And they made 2 payments already because we went from 4 weeks to 8 weeks, right? Don't want them to know that you did nothing. So we got to the point where if we don't have an adjustment to make that day, we take the wires out, we clean them off, we flip them over and put them back in. Do something. But, you got to make sure you do something because you're getting paid to do something, right? Otherwise, you create a management problem. And that's what happens. I mean, I can tell you when I first started doing Damon, I mean, I was working 4.5 days a week, right? And I was working my tail off, working 4.5 days a week. And then my schedule started thinning out, and I cut down to 4 days a week. And then it was 3.5 days a week. And I kept saying, man, I was getting nervous. I said, what? I kept looking at all these holes in my schedule. And I'm saying, what's going on? So I sat down with my bookkeeper, my wife, and I said, what's going on, man? We have all these gaps in our schedule. She says, well, I don't know, but our income's way up. Well, just think about that. If you have 100 patients, right, and you had them coming back every 4 weeks, and now you move those 100 patients and come back every 8 weeks, you just cut your schedule in half. And all of a sudden, you got free time. Well, that's what happened to me. I ended up working 3 days a week. Not bad, right? Starting with 50 cases in 1997. I did 50 cases, never looked back. My staff didn't like me at first when we first started doing that. They hated me, as a matter of fact. They were upset because they had to learn this new thing, opening doors. All right? And there was a big learning curve on the early brackets. Right? But guess what? After 2 visits, 16 weeks, they were running out with the models and showing me, "Doc, look at Johnny's teeth. Look at Mary's teeth." They couldn't believe what they were seeing. And I would just stand there and go, "See? That's why I changed." Because I never made a wholesale change until then. Okay? So reposition the brackets. Do it right away. Otherwise, you're going to end up with problems, like this young lady did. I bet you didn't know the water was that deep. Amazing what you can find on the internet. All right, so we reposition the bracket, and then we fix it. All right. So the jig advantage, visualization. Now these slides is Rumsey here? No, he's not. So these slides I got from Rumsey, or not, the slides, the brackets and positions and the teeth. He did all this, so I want to give him credit for it. And we can take the brackets and move them around and set up cases. So I've set this up to show you how we bond brackets using his material. So he's from Thailand here. I believe he's from Bangkok, isn't he? Yes, right? So I just want to give him credit for that. So it enables us to create these malocclusions. Now, if you look at this, you look at the jigs, right? These look pretty good. But what do jigs do? It can sure tell you that you've messed up on your lower bonding, can't you? Right? They look awful, don't they? I didn't have my second cup of coffee. I don't know, but I set that up for purposes. So what do you want to do? There's the only 2 good ones. You've got to repo the rest of them. Okay? I like to put the jigs on. If I have to reshape a canine, I put the jig on to try and match this, and then I reshape that cuss tip. So you can do all those little things with jigs, or you can reshape it first. But here on the bottom, you got to repo 4 teeth, because those are way out of position. Okay. Now it looks better. Okay. So Dwight talked about this wedge, right? Creating a wedge. So the wedge is where the line goes through the center of the brackets, And the opening wedge occurs, this posterior wedge occurs when you draw a line on the cuss tips. So as you go from back to front, that wedge should be opening up. Right. So it's easy to visualize this on straight teeth, isn't it? All right, but what happens when you have a malocclusion, like Jennifer's? How do you position brackets then? All right? That's what we're going to learn. So early on, it became obvious to me that I had to get better at bonding. And I had a really good teacher, can't remember his name now, escapes me. Who taught bonding from Ormco early on? Michael Schwartz, good. I know I could rely on Sandra. She's got a memory that I don't have, right? Michael Schwartz taught bonding, and he taught me about positioning. This is in conventional, offsetting brackets to rotations and things like that. So I'm going to take you through, what I learned back then. All right. So here I created Jennifer's malocclusion. Okay. So that's Jennifer that we just looked at, and that's what happened to her teeth. But how did I get there? All right. So the first thing that we do is we bond our second molar. All right. So I bond 7654, upper and lower. So we isolate, not with a retractor, we isolate with a sphenometer, right, a triangle on the cheek, and I use a mirror back and forth to just retract. So I can see those teeth. I don't have the retractor in the way. It doesn't get in my way. The worst one in the world for bonding posterior teeth is the one with all the hoses. I can't remember what the name of that is, but anyway, you got to have clearance. You got to be able to visualize. And the second molar is the toughest one to visualize. So my objective is to get this way occlusal and parallel to the occlusal surface. That's all I want to do. So I don't want to put it at an FA point like this one. I want this more occlusal. So I would rather have that tooth out of occlusion a little bit than hanging down with a palatal cusp that creates a balancing contact at the end of treatment. So I'd rather take it out of play. All right? Then I put my second bicuspid on. And how do I line that up? I look at the slots. Okay? Let's do it in the malocclusion. Molar's tipped, right? I can see that on the Panorex. So I put my molar on occlusal. I put this one on directly in the center, FA point. That's what Larry Andrews called it, facial axis, right? All right, and then the bicuspid, I have to make one artistic decision. I have to look at one marginal ridge. That's it, one marginal ridge. I look at the first molar, I look at the second bicuspid. All right, and I know that that marginal ridge is hanging down, so I place that bracket so the slots align with the discrepancy in the marginal ridges. Okay? So unlike this, the slots should be even. Here, this tooth is extruded more and hanging down, the distal tips. So that's what I should see. Now it's just anatomy. That's the one decision you have to make. So I put the first bicuspid on, and what do I know about the first bicuspid? I should see more cuss tip hanging down on the upper first bicuspid. All right? It has a longer buccal cusp. So now I don't have to look at the marginal ridge here. I just want to make sure when I position this bracket that I'm going to see more cuss tip. That's it. That's all I'm looking for. I look at it. I look at the Panorex, see its tip. I put it on, and I have more cuss tip showing on my first bicuspid. I get the canine, I do the same thing. I need more cuss tip showing than I do on the first bi. I don't care if that's in orbit. Doesn't matter that it's up there. I'm just going to put the canine at the same position. I want to see more cuss tip here than I do here, and then here. Okay? Cuss tip, more cuss tip, more cuss tip. Then the laterals go on by smile arc. And the lateral jig always hangs off a little bit if I'm putting them on FA point. That's it. So when I put those on, right, and I put a wire through the molar, which is in good position at FA point, what happens to the second molar? It has to tip back and come up. Second bicuspid has to come up. First bicuspid has to come up. Canine has to come down. There's our straight teeth. There's your wedge. Simple as that. So it all one artistic decision. Look at your second bi and your first molar, judge how much that one marginal ridge is off, put your bracket on, and then you keep going forward from that by looking at anatomy. It's as simple as that to put brackets on in good position. That's how I did Jennifer. You see the marginal ridge and the marginal ridge? So when I put those brackets on, they had to be way off. They had to be like this. You see it? And this one happens to be leaning in. All right, and then what happened at the finish? I repositioned one bracket on that side, that canine. And it wasn't because of height, it was because of rotation. Right? So that's how you get those beautiful finishes. That's how Dr. Damon does it. That's how he's got these magnificent finishes. I would only love to get a case treated as well as he treats a case. He's amazing. But that's how it's done. It's very simple to get that if you follow those rules. Incisor position, smile arc. This is, again, a slide from Rumsey. 1 millimeter higher on the gingival. The incisor should be a little bit higher than the canines. All right? And you're going to get that nice smile arc. Okay? Let's look at smile arc. If I put this wire in the two laterals, you can see these centrals have to come down, right? That's what I want. Let's move the lateral into the canines. All right? What has to happen? This canine's in pretty good position. Lateral has to come down, central has to come down, central has to come down, lateral has to come down. What's this canine have to do? It has to torque. That's why I have a high torque bracket on it. So it's all set up for you. That's why you need the torques. So she was a phase 1. We're going into phase 2. Here's the molar tube. Marginal ridges. They're perfectly even. So shouldn't my slot here on the molar be even here? And look at the anatomy, right? More cusp tip. These marginal ridges are on, but the more cusp tip gave it to me. More cusp tip here. And the tooth is rotated. It's more mesial. And that's how we do it. So when you look at my cases, you better see this all the time. When you look at your cases, you better see that. Cusp tip, more cusp tip, more cusp tip. And you'll be able to get those same finishes that Dr. Damon. All right? So here's the setup. I put that wire through here. What has to happen? Canine has to extrude. These teeth are lined up. There's your wedge. Every time. Now the bite, look at the marginal ridge here. Here's the molar. Where's the marginal ridge? Bicuspid's way up from here. So the bracket slot should be up. How did I put the first bicuspid on? Anatomy. More cusp tip. That's it. Don't have to look at these marginal ridges. It's done. I want to, in the lower, that's not the case. The lower, they're all going to be at the same height. I'll just give that away ahead of time. It's the upper, the aesthetic arch, that matters. So this is what you're going to see. All right? Every single time. If you don't, this is the opposite side now. Here's your canine. Here's your first bicuspid. I'm sorry, this first bicuspid, here's your second bicuspid, right? Cusp tip, more cusp tip. If you don't do that, if you put them at the same height, like I used to do, guess what you got? Every single time. I was stepping down the first bicuspid or repositioning the bracket. Until I finally one day woke up and said, everybody knows what the definition of insanity does, right? To do the same thing over and over again and expect a different result. Well, one day I figured out, maybe I should change the position of that bracket because I keep doing the same thing, same mistake over and over again. So it's different. You need to have that height difference, not the same. That's what you need. So bicuspid heights are different. And the lower bis are the same. Even the molars are the same. The upper bi is the aesthetic arch, and there has to be that differential. You need a Panorex to visualize. All right? There's your cuss tip. And you can see that this canine needs tip, all right? And it also needs to extrude. All right, so that's going to happen. You can see the wire, what it's doing. I don't take a Panorex to check my bracket positions. We were taking a Panorex because we had a partially impacted second molar. So we were sending that out. But you can see that the bracket positions that I have on the X-ray are doing exactly what they need to do. All right? Sizal edges. This is generally the relationship we're going to see. Centrals are always lower and a little bit lower than canine to get the smile arc. And that lateral jig should be hanging off all the time. Look at the bicuspid relationship. The same. Jigs in height. Look at this little differential between the edges. You see it when you put the brackets on. What has to happen? This tooth either moves up or this one moves down. You get that correction. So I love the jigs. They're probably going away at some point. Some of the jigs have gone away already, but I think, and if you like this, if you like all your incisors at the same edge, you can do that, right? That's a matter of artistic preference. I like to have my laterals a little higher. And there's a reason that we took the X-ray, not to check. And if I have time today, I'm going to show you a little, I don't know if I'll have time Friday, but maybe we'll get to show you about how to get that molar up without sending them to the surgeon. Okay. Anterior placement, right? Just everything FA point. Okay. So you see those canine tips going to be a little bit higher. All right, let's talk about offsetting. Direct center of the teeth. Those two incisors are right on. What about these two? Got to offset them to the rotations. That's how you're going to pull out the rotation. Take a look. Look at the lower incisors. All right. See where they're offset for the rotation. Look at the canines. Offset for rotation. These two are dead square on. Way mesial on those canines. And like I said, you don't have to reposition these. You'll understand that better on Friday. But you're never filling up that slot. If you don't fill up the slot, you don't have to reposition them. Because you got a lot of play in that 1925 wire. It just pulls out the rotation. Okay. So initial setup, this is typical initial setup. And there's a shorty elastic started, first visit. It's almost routine, the way we do it. And I don't care where these teeth are. One can be in orbit, and you can still put the bracket on in the right position. That was from phase 1. We had a little bar on there. We took that off, and we put turbos.
Break, 2:30, not 3:30. 2:30 is the break.
2:30 is the break.
Yeah, like now.
Okay. We got a natural break. He said 3:30. It was 2:30. Okay. So let's take a little break. We're going to meet back here at 3 o'clock. And what I'm going to show you is where we're at today. So I'm going to take you into what we're doing and show you some difficult problems that treat very easily. Okay. So let's take a break. Be back at 3 o'clock. We're going to finish at 4:30, 3 to 4:30, and I promise you I'll buy you a cocktail. Well, I'm not really going to buy it. They're going to be out there. Okay? So let's take a break.